Hello, everybody. My name is Yonit Hagoel Karnieli. I'm a speech and language therapist specializing in AAC. I'm working in Israel at Ezer Mizion. It's the largest NGO in Israel that helps people in health distress. I am directing the National AAC Center since 1997, a center servicing the entire population of Israel. Within the national service that we have, there is a division of experts. It's called the OMER team, which include 5 speech and language therapists and 3 occupational therapists. All of us are specializing in AAC. Together, we serve as a team of experts, develop materials and projects in the field of AAC, perform evaluation across the country for complex cases of all ages, and in addition, we lead trainings, seminars, and workshops. Before I begin, I'm very happy to join you for the 3rd annual conference. Unfortunately, not face-to-face, but online. Let's hope that next year we're going to see each other like last year and the year before that. Let me share the screen. Okay. So the subject today under discussion is patient-provider communication for COVID-19 patients on respirators, on ventilators. The corona reality that we face globally has created new needs that directly connect to our work of recent years at the area of AAC. Corona patients in intensive care wards in the hospitals who have already woken up but still need intubation cannot use speech to express their needs and wants. Lack of communication leads to communication vulnerability, which hinders care and recovery. We feel that it is our duty to provide support by helping staff communicate with these patients. So today, slide presentation is based on a project that have been underway in recent years within our OMER Center. It is one of the biggest projects that we have implemented in the last 5 years, and it is called Don't Give Up on the Connection. Yedida, one of our team members that we see a picture here, she is giving a lecture here as well, or she already has given, about beginner communication. And I, with the help of the OMER Center staff, have produced a guide for communication for hospitalized patients. It's geared for patients that are in intensive care units and other wards, mostly internal wards, who have lost the ability to communicate through speech. The objective of the guide is to provide simple means of communication which do not require operative capability. They not require the communication partner and the patient to have any professional training or operative abilities. Hospital staff members have begun using these kits because they saw the advantage of understanding the patient's unique needs. The various boards provide a system of communication using from spelling word boards on one hand and symbol boards on the other, focusing on the specific needs of patients in such situation, like I need to be turned over, I need suction, etc., or I want to call a member of my family, or I have a question regarding my health. And this is only a part of the entire system of tools. Our work on the guide in recent year led in early March within the first wave of corona patients that were hospitalized to prepare a capsule that I will discuss in this lecture. So some global data background from the end of September, in which that was the time that I prepared the slideshow. Data taken from the World Health Organization that talks about 36 million confirmed cases. I'm sure that now the number have risen and more than 1 million deaths. Every patient is in serious condition. Every patient that is in serious condition, is at risk for communication challenges. Last point that I want to refer very shortly for people who do use ASC, may be in even a higher risk group because existing medical condition. ASC user, even though this lecture will not deal with them specifically, hospitalized during Corona poses an even greater dangers for this community. Some of them have associated illnesses, some of them has neurological problems, and they all come to the hospital with an already existing communication disorder. In the case study that I will present later on, I will speak about a girl with ASD and developmental delay who had Corona and what has happened to them, to her. So let's take a few minutes and step out of the subject under discussion here today, which is communication during Corona, and take a general look at the ICU world. What do we know about the topic of communication in ICU? Most of the research and the practical clinical knowledge we have come from wards and other studies carried in the US. I have plenty of material and would be happy to send the bibliography to anyone who requests it. But among the medical conditions that led to hospitalization in the ICU are many neurological illnesses, traffic accidents, head injuries, etc., post-CVA. For many of these patients, the need arises for intubation, and there is a risk for associated problems. Let's look at them. Sensory problems, for example, vision and hearing difficulties, speech impairment, of course, problems in hearing, in reading and writing in regards to most seriously patients in advanced ages, which are hospitalized in ICU. So basically we encounter challenges on both sides from two directions, on the part of the hospitalized patient and on the part of the caregiver, the medical staff. Treatment time is limited due to understaffing. The caregiving staff lacks knowledge. I'm not talking about SLPs, but about nurses and doctors who have no knowledge of ASC. And in a lot of words, speech clinician will not be brought in for the purpose of communication, but only for the purpose of swallowing. Even if the knowledge exists from prior cases, the caregiving staff, doctors and nurses, do not have the skill to practically apply that knowledge. There's a story about a neurosurgeon employed in the ICU ward in a very large hospital in the center of Israel. He was injured in a car accident coming home from his shift at the hospital, taken back to the same place that he has left a few hours before. The family asked us to come and fit him with an ASC system, and the match was a success, and the patient used the system. A patient doctor even made a decision regarding his own plan of care. Was there a change in the communication climate in that ICU ward? The answer is unfortunately no. It took some more years and other patients, other family members who has intervened on behalf of the patient and asked and demand ASC solution, and a lot of awareness to make this leap. So we cannot let ourselves be discouraged. In Corona ward in particular, there is a concern for infection, and in a lot of ICU during Corona, SLP do not step in. So if we see the patient with breathing difficulties, with alertness problem, with a problem with motor accessibility, being quarantined sometimes, and the service provider with limited time for care, fear in corona of being infected, lack of knowledge, skills, and sometimes position. There is a communication crisis in these places. So if we look at the challenges at the patient level, even a patient with only a shortness of breath faces the ability to use only brief expressions. The patient cannot use long utterances, reduced loudness, cannot carry out his voice, and faces hypoxia. Not to talk about oxygen goggles, intubation, BiPAP, ventilation, and mostly tracheostomy. That it's not a question of difficulty using communication, but inability using communication via speech. So it's impossible to communicate at all. It's also important to take into account the time period needed for intubation. From feedback that I received from corona wards in Israel, in most cases, it's only a question of a few days. But yesterday, I got a phone call from a family of corona patients that have woken up several weeks ago and still hasn't been successfully weaned from the intubation. He was without a communication system. It is clear that we must intercede in such a case. Other issue is the need we need to consider is when sedation is being used, it will affect cognition and alertness. So we need to figure that question out as well. So let's continue now to challenges on the environmental level. Two clinicians, Rachel Santiago and Tammy Altschuler, did a study analyzing the environmental blocks that assimilation of ASC in ICU. They took the Pat Miranda participation model. It's a model that Pat Miranda built already in 1998 and has upgraded since then. The participation model is a model that for evaluation of and intervention of ASC, which addresses the demands of participation on the part of the individual using the ASC and serve as a basis for building treatment intervention, when the goal is always participation in the activity. I don't want to really go far into delving into the model, but one of the areas that the model addresses is evaluating blocks and opportunity. And Santiago and Altschuler study related to the environmental block and observed that a lack of resources poses the most significant block, followed by lack of knowledge. This study really provides a clear glint of light regarding the value of intervention in ICU, because if we give the resources in 34%, we're going to solve a problem. So what did we learn from studies that analyzes the state of intubated patient before corona? Or if we want to rephrase the question, why is it so important to introduce ASC solution into ICU and make it accessible? Because again, studies show that communication challenges are the most common stress factor reported by hospitalized patients after being hospitalized. Panic, anxiety, and sleeping problem are all connected to the inability to communicate. 62% of the hospitalized patients report a high level of frustration. Emotionally, they sense a lack of control and they feel helplessness, which has a snowball effect, leading to anxiety, depression, and despair. Medical literature describes the connection between lack of communication and aggravation of symptoms, as well as the effect of communication accessibility on the patient's condition. We know that patients with access to effective communication receive less sedation, transfer more quickly to care outside of the ICU into other wards, less stressed, are more pleased by the information they received about the progress of the illness, and feel more in control. And let's remember that hospitals, at least in Israel, are signed on a hospital patient pact, which included the right of the patient to ask, to object, to request, a pact that cannot be implemented if the patient is unable to communicate. And what you see in the picture in the slide is myself communicating with the patient via a simple AAC solution of a letterboard. So, came March 2020 and Corona. So let's try to characterize the patients. They are different as a population from the patient that we worked with until Corona. A population that is primarily elderly, all intubated, after having woken up from sedation usually, hospitalized in ICU wards or in respiratory rehabilitation wards for Corona patients. Without neurological or cognitive problem as a prominent factor in most cases, and mostly the time span until they are weaned from the intubation is brief. They are without relatives at their bedsides. The staff is in protective grab. It comes in for brief measured time period. Contact of the staff with the patient is very limited. I must quote you something that an SLP friend of mine who is entering a Corona ward on a regular basis, is in one of the largest hospitals in Israel. She described a situation of a very brief window of time, a few scant hours, is allotted for the entire treatment regimen of all of its components for all the patient. Problem of access to communication devices, no possibility to use the phone or computer. In all the cases, woken up after sedation. And again, the total isolation from family members is crucial in this population. So imagine the communication barriers that occur while using protective clothing. That needs to be put on when you go into a Corona ward. But, although there are some steps that can be used in order to break these barriers. In some of the wards, ICU wards in Israel, we use hospital clowns in order to lighten up the atmosphere sometimes. Because what we know, uses of masks reduce speech intelligibility, reduce facial expression. Protective clothes may frighten patients sometimes. So there are some steps that could be taken in order to help the situation, like ensure that the patient has his eyeglasses, his hearing aids when he needs to speak slowly, to check that the patient understood what was being said to him. Put a picture on top of the protective gear. Describe your facial expression, explain to the patient what is needed for kids, to do some things with the like I told you about the funny faces that are being used, and the clowns. So our work up to March 20 was to meet with patients presently or previously hospitalized in hospitals with communication vulnerability that did not receive a response, or to answer questions from hospital people concerning what to do about a patient. They don't have the AC solution, they don't know what to do. So we needed to step in and help the caregiver, the nurses, the doctors, the SLPs in the wards. We got phone calls and email from friends, relatives of patients, caregivers of patients who are hospitalized and cannot speak. Many phone calls, a huge amount of hardship from therapists, and family members. So about 3 years ago, we decided to take action, and in the course of 2 years of work, we prepared and posted the guide. Let me, for a minute, go over the sketch of the structural tree in the guide. But before that, it's an online guide geared for therapists and family members, and by answering a yes and no question about the patient capability, the user can access communication solution very readily available for downloading and demonstration. We have some video clips that show what to do with part of the solution. It's free of charge. We do not require entering identification information, and just to go in and go through this flow chart, which is really, when you see it like this, it looks very complex, but basically when you go inside and answer a yes and no question, let's say after you pass through the introduction to expression, does the person have a clear sign of yes and no? If he doesn't have a clear sign of yes and no, how can we check if there are signs? And if no, how we will learn if it's a yes and no and what to do about it. If he has a clear yes and no signs, is the person's speech understood? If he speaks but the speech is not really understood, we give tips to improve comprehensibility. If he does not speak at all, can he write? If he can write, we use writing materials like boards and marker and give examples. If he cannot write, can he spell by pointing or by looking? If he can spell by pointing or by looking, we have gaze and pointing boards that could be downloaded. If he cannot spell by pointing or looking, can he point at picture or full words, etc., etc., until you reach the end of this flow chart. So again, in March, we in Israel went very quickly from one day to another almost into a very tight lockdown. And I sat and thought, how could I harness our knowledge for the benefit of the situation that was created on the field? The beginning was, of course, from the guide for hospitalized patients that I showed you, and some resources from the patient-provider communication in the USA. We prepared a limited kit of ASC tool for caregiving staff, and support was offered to the staff working in the fields within the ICU wards. The kit was prepared in 3 languages, in Hebrew, Russian, and Arabic, and later on in English, and was distributed to 12 hospitals, all for Israel. Whatever hospital had a corona ward, we approached them. From among the very broad range of options existing in the guide, I chose some assistive tool that could be used with a population of intubated corona patient. And I looked at other resources as well that were globally floating around, and chose some tools from the patient provider communication org in the USA for the ability to use an open resource like that. I thank them deeply. It was a huge amount of help. I took into account the specific characteristic of the population, the problematic nature of the hospitalization condition and the illness, and the need for a very simple, very basic solution. In most cases, again, for a very brief span of time until respiratory rehabilitation. We prepared them, as I said, in 3 languages, and later on in another one. And the introduction of the kit takes into account the fact that most staff members have no experience in the field of using AAC and make it accessible. Therefore, there is a very brief general explanatory page, which I'll show you in a few minutes. So it's a guidance and general information for communication support. And let's pass through that. It could be downloaded from our site and available also in hard copy in laminated version, ready for use. So the guidance, which is the first tool, gives a recommendation for communication with the patient who has trouble communication via speech. So what's the alert state of the patient, what are the assistive accessory, how we support the time and place orientation for the patient, how do we support the writing or typing, maybe sometimes using object, visual support to clarify the spoken message, and to find out, to get a confirmation from the patient, which is the very critical advice, that the patient understood correctly what was being said to him. In every one of the tools that I'm going to show now, aside from the explanatory page, there's an explanation for the use of each tool. For example, how the communication partner knows how to scan the options. So aside from the downloading in our website, in addition to, due to the severe hardship that accompanied for us, especially the first lockdown, and because I understood that no staff, a member in the Corona ward, would have the time or the ability to enter our website, to check out the materials, to print them, to laminate them. We prepared pre-packed packages of all this information, all this data, and send out the kits via the national deployment of Ezer Mizion. We have we have 30,000 volunteers all over Israel. Out of them, 14,000 are helping through a net of deliveries. Again, only to do with medical and health issues. So a small group of volunteers help translate the boards to Russian, to Arabic, and other prepare the board in the grid. And again, all the kits were delivered to the hospital across the country according to their needs. Here too, we had the drama of how to rendezvous with the clinician in charge. Hint, meet me next to the booth at the southern entrance of the hospital. I'll be wearing a white coat and I'll have glasses and a ponytail. Or at 6:45 in the morning in the parking lot of my building. Put it down on the floor and move a few feet away before I can come sanitize the handle of the package and take the material, pick up the material. So the guidance and general information. And the next one, we had two formats of yes and no boards with 3-4 messages, along with an explanation, which we will see soon. So we have yes, no, I don't know, maybe, and later. All is color-coded. And again, this is the instruction sheet. So basically, how to establish set signs of yes and no, how to formulate each question as a closed question and not an open one. If it's not clear how to do it. So basically, when the medical, let's say a nurse or a doctor, holds a yes and no board towards the patient, the yes and no is towards the patient, but the instruction is the other side of the page will hold the instruction of how to use. So the patient will see the yes and no, but the nurse or the doctor is going to see the instruction on the other side on the flip side of the tool. Another one is spelling boards. And again, taken from the guide. In the guide, we have several boards, but here we prepared only, I prepared only the most commonly used boards from our experience. And it's suitable for auditory scanning by the communication partner with an explanation of a page here, sorry, of how to do auditory scanning. Needs boards in 3 languages. I chose 2 boards, a shorter one and an expanded one, in order to adapt the boards to the needs of different users, either those who are groggy or with a vision problem or without eyeglasses. So it's going to be a short one or an expanded one for people who are still intubated, but very there for the team to talk with. The 5th one, and this is the explanation, sorry. The 5th one is the pain scale, taken from the communication system developed by the National American website that I told you about, which includes this pain scale. And again, these are the how to use instruction, which is on the other side of this page. So how did I approach? We prepared it, and I needed to bring it to the hospital somehow. So we approached key figures in various hospitals. I also turned via our professional Facebook group, Speech Clinician Communicate, to ask if anybody is familiar with a key figure in the hospitals, and I received a great deal of help via the forum. After we sent out the kits, we supported the staff via phone guidance or with Zoom meetings when necessary when they receive the kits. Up till now, I get phone calls to send materials with the second wave of Corona that hit us in August, September. And there are many calls from family members who heard about the kits and asked to receive one. And to this day, I coordinate calls from a relative of intubated Corona patient that need help. This is the picture of the volunteer of Ezer Mizion who went to the chief speech clinician of one of our leading hospitals, Kaplan hospitals in the south of Israel, and he brought the kit to her in her car park before she went to work. I really want to single out the process with Kaplan Hospital as it appeared there, because she has received the guidance on the phone and related the guidance within the hospital to the ward staff. And you can see what the head nurse Yael writes. She says, the guidance are clear and they facilitate communication with the patient receiving respiration via tracheostomy or tubus. The guides are user-friendly and accessible. They came at the right time to the right place. Please send more guide in a selection of languages. So we were asked to send the guides only in Hebrew, and they needed some guides in Arabic and Russian as well. We sent them within 1 day. She had them in her hand. Because what happened there at the hospital that the chief speech clinician got a explanation from me, and she guided the ward staff. So basically, at the base of the success of future projects, given the problematic nature of this illness, is preparing the staff in advance. And I will relate to this point later on. And here, some more picture taken for a ward for rehabilitation after Corona. So we have here people who are Corona patients, but not dangerous anymore. Basically, two weeks after they got Corona, but still hospitalized, still ventilated. So they really needed the tool in order to facilitate their communication. And the kids also infiltrated to a general ICU ward due to the exposure of the staff members in the corona ward. So the same process was reported in other hospitals as well, which the kids found a way into the general wards, into internal medicine wards, and the staff started using them with patients without corona too. And from our point of view, this is a great glint of light within this difficult situation, because we've been knocking on the doors of ICU wards and hospitals for many, many years now. So basically the corona opened up a window when the door was still closed for other patients, and presented opportunity for more staff members to acquire knowledge and provide assistance, which is really wonderful. Up to date, we have provided more than 250 kits with the deployment described that I told you about. And in addition to kits, lots of visits to the website. So the website went at March. So you see what's going on in March, and during April and May and June, 4,200 entries by 1,390 people. So how can the ward staff prepare to program themselves in order to facilitate AAC? We don't really have time to go into operative program, but the slide has an outline of prepare your ward for the next wave. We would be happy to be in contact with any staff or staff member who wishes to expand his knowledge on the subject of how to acquire knowledge, how to learn about needs, printing, how to prepare the stock of accessories, to check if the patient can communicate, training, and identifying key figures. So some basic tools, tip to how to communicate with the patient taken from our website. And now I would like to share a story with you that came my way from a hospital some 30 kilometers away from where I live. The head clinician called me about a 12-year-old girl living in a residence for children and teens with complex disability. She has a ASD and a developmental delay, severe one. She got corona and was transferred very quickly to the hospital. She doesn't speak, and she arrived without her communication system because everything was very quick and with lots of panic at the beginning. So her status was really appalling because she needed to be tranquilized. She needed to be sedated because she couldn't understand what was going on around her. So from far, I took over the editing of a hospital iPad. I installed the grid free, found out what were the main communication needs in the hospital, how this child communicates before being hospitalized, because I talked with a clinician in her residence. I talked with the clinician in the hospital care to find out what the needs were. So in the hospital, they allocated a nurse to take care of her, and the nurse was instructed in the way to how to communicate with the iPad, with boards that were built on the grid, and with simple boards as well. And in a matter of 2 days, the medical staff took away the tranquilizing medication, and she used the AAC solution to communicate. So that was a good end to her story. I would like to thank you, thank you with all my friends at Omer, to the dedicated staff of Lenders in Israel and the National Center for ASC in Ezer Mizion. And we'll meet for some question if you have one.